Lastly, we're going to talk about the absorption of kind of other things, vitamins, electrolytes, and water. So first is vitamins. So we have two kind of major sections of vitamins. We have fat soluble ones, so they interact with fat, and we have water soluble ones, so they only interact with water. So fat soluble ones, the A, D, E, and K, so are going to be carried with fat digestion. So they are actually going to be mixed in those micelles. So they're going to be kind of in that big fat globule, emulsified by bile salts, and then added and included in micelles. And they can diffuse just like with lipids and diffuse together. Water soluble vitamins don't need to follow anything because they can just be dissolved in the small intestine and in all of the products that are there. So they can be absorbed by kind of any different way. So they can be absorbed by diffusion, passively, or active. So they can have facilitated diffusion, they can have regular diffusion, or they can have active transport as well. Remember, vitamin B12 is large and polar, so it's a charged molecule. So it needs to bind with intrinsic factor made by the stomach, made by the parietal cells, so that it can be absorbed that way. So it's different in the sense that it has to bind with intrinsic factor and absorbed by endocytosis because it's so large. So it can't even be diffused or kind of actively transported. It has to be in vesicles and brought in. In the large intestine, vitamin K and the B vitamins that are made by the bacteria can be absorbed there. So there is some absorption happening in the large intestine, but it's going to be just those vitamins that have been made there. If you're looking at electrolytes, remember those are ions. So most of the ions are going to be transported and actively transported in the length of the small intestine. So all the way down the small intestine, we're going to be taking in those ions that we're consuming. Iron. So iron needed to make hemoglobin. So for blood, calcium ions are going to be absorbed a lot in the duodenum, so the beginning of the small intestine. Sodium absorption, we see a lot when we're looking at the transport. So again, we have the sodium potassium pump, and we use it to also transport glucose and amino acids. So sodium absorption does go hand in hand with glucose and amino acid transport. Chloride also transported actively, so brought into the cells. And potassium, so K plus is potassium, is going to go in response to water gradients, so osmotic gradients. So water is absorbed and it's going to follow water, basically what it means. So if water absorption isn't that great or there's not a lot of water, then you're not going to have as much potassium absorption as you would if you do have water. So as water is absorbed or reabsorbed into the body, potassium follows. And we're pretty effective. So, in your small intestine, the amount that is consumed is the amount that's absorbed. So, it's very efficient and effective in making sure that we're absorbing all along the length of the small intestine. That's a long time that you can keep absorbing electrolytes. So, along all of the duodenum, the jejunum, and the ileum, we can have absorption that gives us extra time to make sure that we're getting as much as possible to get those electrolytes. And then if we need to filter them out, that'll be our next section when we talk about the kidneys. So if we were having too much, we can have the kidneys sort through that. So iron and calcium absorption again is related, not necessarily having all the absorption. So the electrolytes like sodium and potassium and things like that are going to be absorbed. Iron and calcium are going to be based on if we need it or not. So iron as an ion actually can be stored in cells, And then it needs to be transported as transferrin because it is damaging if it's just free iron. You can't have that in the body. And then calcium absorption we've discussed way back in AMP2 and our endocrine system because we need parathyroid hormone and vitamin D to regulate calcium absorption. So remember, calcium absorption is dependent on vitamin D and parathyroid hormone saying that calcium levels are low and we need more. Looking at the absorption of water, so 9 liters of water is actually added to the small intestine when digestion and absorption is occurring. So most is going to be from various secretions, and about 95% of that is brought or reabsorbed back by osmosis. So again, osmosis is high concentration to low concentration. It's just the diffusion of liquid. So most of it is going to be just absorbed that way. And the rest is going to happen in the large intestine. You can also add to osmosis by changing the solute concentration. So remember, if we're kind of changing the solute concentration, water is going to follow solutes. So if you're taking all those electrolytes, especially like sodium, and you're taking it into the body, water wants to follow sodium as always. So wherever sodium goes, water will follow it. And that's the same with other electrolytes as well. So as you are absorbing all those electrolytes, you are increasing your absorption of water as well. Just looking briefly at the large intestine, you can actually just kind of looking at the bacterial load. There is such a thing as antibiotic associated diarrhea, and actually about 14,000 deaths in the US per year. And most of that's going to be, if you've ever heard C. diff or Clostridium difficile, that's an anaerobic bacterium, meaning it doesn't use oxygen to metabolize anything. And that is going to be in the large intestine. So normally Clostridial difficile is going to be in your large intestine, but at low numbers because it's outcompeted by the rest of the bacteria. So it doesn't cause a problem if there's only a few of them. It's when they're able to take over and colonize a large portion of the colon that causes issue. So with antibiotics, they are not selective. They're going to kill various species of bacteria. They don't just choose one species, they're going to wipe them all out. And C. diff, Clostridium difficile, is difficult to kill. So it's a specific antibiotic, and sometimes it's even more difficult that they're actually resistant to antibiotics. So if you're killing all the other bacteria that are out competing them, then they can just start growing and growing and growing. So you can cause inflammation of the colon, and it can cause what we call pseudomembranous colitis. Colitis is inflammation of the colon, and that can lead to bowel perforation, so holes popping the bowel. And if you are allowing feces or fecal matter to go inside your abdominal cavity, then you can lead to sepsis or infection in the bloodstream. So C. diff, you can't really use antibiotics because they are resistant and they are difficult to treat. And oftentimes we've been using actual fecal transplants. So taking feces from someone you live with, so usually it's a family member, and you can give the fecal transplant to replace those healthy bacteria or that were killed by the antibiotic and recolonize, and then it can start to compete with C. difficile, and they can suppress it. So actually giving a fecal transplant, fecal matter, is a good treatment for it. Also looking at other disorders of the digestive system, periodontal disease, so starting with oral cavity, dental plaque between gums and teeth, bacteria can cause gingivitis, tooth decay, and eventually breaking down the periodontal ligaments, which makes loose teeth and the bone around it. So periodontal disease, then losing teeth, or you're losing mechanical digestion of being able to chew and break down your food. Esophagitis, anytime you have an itis, it's inflammation. So esophagitis is inflammation of the esophagus. So usually, again, it's from stomach acids leaking through the lower esophageal sphincter or diaphragmatic constriction, and it comes into the esophagus. So remember, stomach is able to handle the pH, the esophagus isn't. So it can never kind of handle constant supply of really significantly low pH material. So you get gastroesophageal reflux. So it's reflux, it's stomach acid going into the esophagus. That's heartburn. But if you have continuous, where you have a weak or leaky sphincter, so it doesn't close all the way, then you can have issues where you can have ulcers and damage to the esophagus. So you get inflammation and you get ulcers and damage to the esophagus. Hepatitis, again, itis is inflammation. This is inflammation of the liver. Eventually, it can lead to cirrhosis, which is going to be where the liver actually can't replace itself and it's replaced by scar tissue, which is not functioning. So, not functioning. So, basically, you still have a liver, but you're surrounded by non functional cells. Well, that makes it so the liver's not working, and that leads to liver failure. You can also have viral hepatitis A, B, and C. The virus actually destroys liver cells and can cause eventually enough inflammation and often enough scar tissue. And that leads to jaundice or icterus, which is going to be the yellowing of the skin because we can't take care of bilirubin. So remember the breakdown of red blood cells and the pigment of hemoglobin to bilirubin. We can't break it down and it actually builds up in the bloodstream and goes to the eyes and the skin and causes that yellowing. Gallstones. So sometimes in the gallbladder, minerals and the bile salts can become too concentrated, less water and just more kind of the salts and minerals. So they kind of compact together and cause stones. Small ones can just be flushed through the bile ducts and then go into the intestines and be excreted that way. But you can also get cholecystitis, which is going to be more damage and inflammation to the gallbladder. So these stones sit around and dance and kind of move around and cause irritation and damage to the gallbladder. They can even block the ducts, the exits, so the cystic and the common bile ducts. So if they're big enough, they get stuck, and then you have kind of backup. And that's when you have to have removal of the gallbladder surgically. You still can produce bile after surgery as long as your liver's okay, but you can't store it. So that's the difference. So gallbladder stores. So you can still eat fatty meals, but it's a lot less bile released because it's not stored. So that makes the difference of kind of how you change your diet. Gastritis, when you have gastro, it's stomach. Itis, again, is inflammation. So now you're talking about inflammation of the stomach. Some things, some drugs, and other components are actually absorbed in the stomach. So aspirin actually is absorbed in the stomach and does have an effect on the stomach. A large amount of alcohol, then you can cause damage and inflammation to the lining of the stomach. Stress, so gastric ulcers that we talked about, or that I'm sure you've heard about. Severe stress, constant stress can have an influence on the lining of your stomach, and actually the breakdown of the lining makes it so it's not resistant to its hydrochloric acid and can cause ulcers or severe damage to the lining. You can also get bacterial infections, or other strong chemicals can cause damage to the lining of the stomach. So peptic ulcers, um, those enzymes like proteases can actually get activated, and acid will um, go through the stomach or the duodenal lining, so it'll actually cause damage, and then we don't have the cells, we don't have the protection. Eventually it can go through the entire lining of either stomach or the duodenum. So gastric ulcer is a peptic ulcer in the stomach wall. Duodenal ulcer is a peptic ulcer in the duodenum. Helicobacter pylori is a bacteria that can cause inflammation of the wall of the stomach or the duodenum. And then it can cause kind of the inflammation that leads to acid and enzymes breaking down the stomach and causing even more damage. So a lot of times it's caused by a bacteria, Helicobacter pylori. Pancreatitis, now we're talking about inflammation of the pancreas. So that can be caused by blockage of the pancreatic duct, mainly, and viral infection. Also, kind of things that you take in, toxic drugs, also alcohol. What happens is, you can imagine all those digestive enzymes are in the acinar part of the pancreas, and you have injury to those cells, and they actually release digestive enzymes that can be activated. So then you're even causing more issue, and that's why it's kind of dangerous, is because it can start digesting the pancreas and breaking down normal tissue. So what has to happen is, you have to treatment is, it is a painful condition. You have to stop the digestive process, and it can cause death if it's not stopped. Enteritis is inflammation of the intestine. So you can have watery bowel movements, so diarrhea. One cause is actually Giardia. It's a protozoan that lives in water, and that can cause inflammation and cause watery bowel movements, because it's messing with your water reabsorption and your solute kind of absorption. You also have dysentery, if you've ever heard that. That's inflammation actually of the large and small intestine, and you see blood and mucus in the diarrhea as well. So when you have enteritis, diarrhea is going to go hand in hand with it, because again, you're messing with water absorption and you're not getting as much, because most of it's happening in the small intestine. So you or in the large intestine, so you're not reabsorbing it and you're defecating it out. Inflammation of the colon, still same thing, diarrhea, so colitis. You're messing with the absorption of water. A lot more water is in the small intestine and in the large intestine. You can also have the opposite, where you get constipation. So this is not having regular bowel movements and defecating. And that's when the more the feces is sitting in the colon, the more water is going to be squeezed out of it. So if it's slowly moving through the colon, then more and more water. So you don't want all the water out. That makes it very, very hard feces and more painful and uncomfortable to defecate, because you have excess water reabsorption, more than you need to. Colorectal cancer is actually the third most common cancer in the States. Both men and women are affected, and it's most common over the age of 50, which is why you start getting colonoscopies at kind of over the age of 45, 50. We see some risk factors of having a diet and a large amount of animal fat and lower fiber, but also there's a genetic component. So it doesn't matter what your diet is, there is kind of a family history of it, then that's a higher risk factor. They begin as kind of small localized tumors. That's what polyps are. So that's why if you go in for a colonoscopy and they say they remove polyps, that's going to be small, kind of localized tumors. If you remove the polyps and get them under control before they can spread, then that prognosis is much better. So that's why getting regular colonoscopies, having polyps removed is good for colorectal cancer.